Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a hypermature cataract where the cortex has been completely absorbed and only the nucleus is remaining. So, we are expecting very weak geniole in this case. Let us observe this surgery. This is the main incision at around 11 o'clock. This is a side port at around 8 o'clock and another side port at around 2 o'clock. And now I am going to stain the anterior capsule with trypan blue dye underneath this air bubble. Air is injected. Underneath this air bubble, trypan blue 0.06% dye is applied over the anterior capsule. The dye is applied on all parts so that there is uniform staining of the capsule. This is a bit of adrenaline. Now the dye is gently washed out. You can see that the nucleus is mobile and there is no cortex in this case. Probably this cataract has gone through hypermature Morgagnian state and the milky fluid has got completely absorbed. Now, as I try to make a puncture over the anterior capsule, I can make out how weak the geniole is. There is wrinkling of the anterior capsule and this is generalized weakness. There is no dehiscent area, but all the genioles are very lax and weak. If we pull it vigorously, it will just come off. Now I give support by the chopper, blunt chopper, and try to do this rhexis. And here it goes to periphery almost. So from here I pull it centrally and as I try to do the rhexis, I find that it is going to be very dangerous. I may cause a genular tear and there may be genular dehiscence in some areas and the whole bag may come off. So, I have asked for this cutter, vitrectomy cutter, and this is the first time I am doing a rhexis with the cutter. I am afraid to go to periphery, so I did a small rhexis with the cutter. And surprisingly, this didn't have any radial tear. So I wonder if this instrument, this 23 gauge vitrectomy cutter, can be used in complicated cases. As I tried to enlarge the rhexis, see the nucleus is rotating. Like a carousel. And now I inject visco take a capsular tension ring and place the ring to support the bag. Here it is. This is the capsular tension ring. The leading end goes into the capsular bag. I could make out that it is going into the capsular bag. There is the capsule is getting notched, so it is in the capsular bag. Now the trailing haptic is taken into the anterior chamber, and I take a Sinski hook to place it in the bag, but I cannot release it. So when it happens that you cannot release the trailing, take another hook and place it, press over the CTR trailing end, and it gets released. Now the bag is well supported. I take a Vanna scissor, make a small cut at 12 o'clock and try to enlarge the rhexis, because the rhexis is very small. I could enlarge on this side. Now I could enlarge on the other side, and the size of the rhexis is about 4.75 millimeter, and this will be okay. Now I place the lens in the bag first. This is a hydrophilic acrylic intraocular lens. It goes behind the nucleus, and the trailing haptic is manipulated to go into the capsular bag. It has gone. So the bag has been supported by the CTR, and the posterior capsule has been supported, or posterior capsule is being protected by the intraocular lens. And now I can manage the nucleus with some relief, some positive expectation that I can do it. I took this pre-chopper and tried to crack the nucleus, and I could do it. This is on crack. The second crack didn't happen much. So I come out. This crack will help in some way in the nucleus management by the phaco handpiece. I go in with 400 vacuum and 40 flow rate. Ultrasonic energy being used is 70%, and I start eating up the nucleus. Pierce it, and make a nice crack. This is being done very gently. Care is being taken not to cause any damage to the anterior capsular rim. And the nucleus is coming bit by bit. Quite hard nucleus, and leathery fibers are there. Almost one heminucleus has been managed. This is the other one. I was in the same setting throughout because the lens is protecting the posterior capsule. Yes, the nucleus has been managed, but there is a small piece of nucleus at the main wound, and here as I inject visco and it comes out. I brought it out by the tip of the visco cannula. Now I washed out the visco. That portion has not been shown. Washed out the visco with Simcoe cannula and bimanual IA. Inject air, inject bit of pilocarpine, and then I inject this triamcinolone acetate to see if there is any vitreous strand anywhere in the anterior chamber. And I found that there is no vitreous strand. The lens is in the bag. The bag has been supported by CTR. It was generalized weakness, and the case is completed nicely. The antechamber is nicely formed, and the case is concluded. We have some post-op pictures. These are taken 48 hours after surgery. Cornea is clear, antechamber is quiet, intraocular pressure is 16 millimeter of mercury, unaided visual acuity is 6/18, and the patient is very happy. Thank you very much for your attention. Hope this video will help you in developing your surgical skills, particularly in cases where the geniole is very weak. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.